Please start.
And the first will be the third paper of the session to compare the rate of posterior capsular rent in posterior polar cataract with modified technique.
Good morning, everybody. As we all know, posterior polar cataract always remains an enigma to every cataract surgeon due to high chances of PCR. Here we would like to discuss the strategies and modification of techniques to prevent PCR in a posterior polar cataract. We would also like to compare our rates of PCR with other existing studies. स्लाइड आगे भी नहीं बढ़ रहा है नहीं बढ़ रहा स्लाइड आगे नहीं बढ़ रहा So in our technique, we preferred approach is usually a temporal clear corneal incision with a 2.2 millimeter square incision, which helps to maintain a closed chamber throughout the surgery. We avoid overfilling the antechamber with viscoelastics. Sometimes a cohesive OVD could be used for capsulorhexis. The size of the capsulorhexis is usually more or equal to 5 millimeter to prevent backflow of the fluid during hydrodelineation. In case of a PCR, it is easier to dial out the nucleus. Cortical cleaving hydrodissection is avoided as it may build up hydraulic pressure rapidly and cause a blowout of the PC. Hydrodelineation separates the endonucleus from the epinucleus, which acts as a mechanical cushion, separating the nucleus from the posterior capsule and preventing transmission of mechanical and fluidic forces to the weakest part of the capsule. Vigorous decompression and nuclear rotation is avoided. Vasavada and Rajatal's technique is of inside-out hydrodelineation is one of the safest method. A central trench is first sculpted. A right angle cannula is used to direct fluid perpendicular to the lens fibers in the desired plane through both the walls of the trench. A golden ring within the lens mandates successful hydrodelineation. It prevents inadvertent subcapsular injection and overcomes the difficulty of introducing the cannula to a significant depth in a dense cataract. We have adopted the similar technique and added viscodissection and viscopeeling of the posterior polar plaque. Nucleus removal is done with a low parameters with a slow motion phaco, power less than 60% with a bottle height of 50 to 70 centimeter, aspiration of 15 to 25 ml and vacuum of 30 to 90 millimeter is considered to be safe. Nucleus removal is done within the cushion of the epinucleus to reduce the risk of posterior capsular rupture, prevent the shallowing of the anterior chamber by use of dispersive viscoelastic through the side ports. Nuclear rotation and wide separation is avoided. Epinucleus is aspirated layer by layer. The thin layer of cortex adherent to the capsule is left behind. Central area attached until the we leave it until the last stage of cortical aspiration is done. The posterior layer along with the plaque is then viscopeeled and aspirated. We have a small clipping. After the capsulorhexis is done, the central trench is made and the desired plane. The central part of the trench is slightly deeper as compared to the periphery. Once the trench is done at the desired depth, the loose cortex is aspirated out. Viscoelastic is injected before removing of the phaco probe. A right angle cannula is now introduced through the wall of the trench to the desired plane and hydrodelineation is performed. It is repeated through the second on this wall. Once hydrodelineation is completed, phacoemulsification is performed. Viscoelastic is injected through the trench below the capsule to lift up the nuclear fragment, which makes phacoemulsification easier. Cortical aspiration is done with a low bottle height. Pulling of cortex is avoided. Tangential movements are safer. And PC polishing should be avoided due to possible presence of a fragile capsule. The posterior polar plaque removal is done at the last stage of cortical aspiration. It could be removed by viscodissection and aspirated by the phaco-tip. Viscodissection protects the posterior capsule. A dispersive OVD is injected between the epinucleus and the posterior capsule that generates space and cordons of the posterior polar plaque. A posterior capsulorhexis can be done in case of an adherent plaque, or an ND-YAG laser could be planned later. We avoid polishing the posterior capsule. Loose cells are irrigated gently with a 1 cc syringe. 18 eyes in our study were considered with posterior polar cataract. Phacoemulsification done by a single surgeon. Rest of the parameters remained the same. 17 eyes were successfully managed with no PCR. 1 incidence of PCR occurred during plaque removal, which was managed well. 5.5% incidence of PCR in our small group of studies. When we compared it with other studies, earlier studies reported incidence of PCR ranging from 26% to 36%. With improved technologies and modified techniques, the incidence of PCR reduced to 6 to 7%. The incidence of PCR in our study is 5.5%, which is comparable to the above studies. To conclude, we have adopted Vasavada and Raj et al.'s technique of inside-out hydrodelineation, which proved to be a safe method in our hands. Our modification of viscopeeling of the posterior plaque further helped in reducing the risk of posterior capsular rent. Thank you.
Thank you very much. So we'll go to the next speaker. Maybe we'll have 2-3 papers and then we will have a question.
Dr. Sayyed here, no? You are there, and Dr. Mitali Jhan. Dr. Mitali, are you there?
No. So this will be the 4th paper, which is a modified 4-flanged intrascleral technique of IOL fixation. Please go ahead.
Good morning, everyone. Today I'll be presenting on modified 4-flanged intrascleral technique of IOL fixation and our 18-month clinical outcomes. It's not moving. Not moving. Optical rehabilitation in patients with aphakia presents a unique surgical challenge. The choice of IOL implantation in aphakia in the presence of little or no capsular support includes ACIOL, iris fixated IOL, and scleral fixated IOL. Each of these techniques has its own merits and demerits. ACIOL has the potential for increased damage to the corneal endothelium and angle structures, whereas iris fixated IOL has increased chances of pigment release and inflammation. Whereas scleral fixated IOL has the advantage of more physiological position near the nodal point of the eye and greater distance from the cornea. Now SF-IOLs are broadly classified as either sutured or sutureless. When we come to the sutured SF-IOL, which was practiced more before, suture erosion and breakage was very high. Because of that, the lens dislocation, lens tilt, and other complications were also seen. Then the concept of glued IOLs was introduced by Dr. Amar Agarwal sir, in which the biological glue, that is a quick-acting surgical fibrin sealant from human blood plasma, is used. With the glued IOLs, the complications were scleral flap issues, haptic extrusion, and the haptic breakage. And the recently developed Yamane technique, it is generally technically challenging, and the IOL decentration and tilt is also more with this technique. Dr. Sergio Canabrava described the forge-flanged technique, which is the intrascleral intraocular lens fixation technique with no flaps, no knots, and no glue. Video. In the original 4-flange technique, the 5-O-proline suture is fed into the lumen of the hypodermic needle within the anterior chamber and exteriorize through a sclerotomy 2 mm from the limbus on either sides. Further description of the technique I'll give in the further part of the paper. Now, my purpose of this study is to report our 18-month clinical experience with the modified 4-flanged intrascleral IOL technique. It is a retrospective study where we considered 52 eyes of 52 patients with a mean follow-up of 18 months. All surgeries were performed by 2 experienced surgeons. The indications for scleral fixated IOLs were mostly intraop zonular dialysis, dislocated IOLs, subluxated IOLs, intraop PCR, and trauma. Now this is the modified 4-flange technique. In this technique, the double needles are pre-prepared by feeding a 5 centimeter long strip of 6-0 Prolene suture into the lumen of a 27 gauge needle. Under direct or microscopic visualization, the needle is then introduced into the sclera 1.75 mm from the limbus. The suture is advanced within the shaft of the needle. Once the suture is visible in the anterior chamber, it is grasped with a microforceps and it is exteriorized. Same is repeated on the other side, 180 degrees apart. Now the suture ends are passed to the eyelets of a PMMA IOL and it is cauterized to create flanges, following which IOL is positioned behind the pupil. Outer sutures are pulled anteriorly and cauterized to create 2 external flanges, which are then buried under the conjunctiva. We believe that this modification may be useful by reducing the maneuvering inside the chamber, as docking of the suture is already done performed outside the eye. Now coming to the results. When compared with the 15 days and the 18 months CDVA, sphere, cylinder and the spherical equivalent, it is not clinically significant, showing that the procedure is stable from the initial and the stability is maintained throughout. And the IOP, mean IOP on day 1 was a bit on the lower side, around 12, and on the 15 days and 18 months it was normal. And these are the clinical pictures showing the stability of the IOL, where we can see the flanges also well centered 180 degrees apart. And this is the UBM post-op 6 months picture, which is showing the well centered IOL. Now coming to the safety profile, the intraoperative complications, there was 1 haptic slippage which we have seen and 1 intraop IOL tilt, 1 haptic breakage. The slippage was due to the inadequate size of the flanges, tilt was due to the loose flanging. Now coming to the post-operative complications, there was flange exposure, IOL tilt and hypotony. This 4-flanged intrascleral technique was better, but then our novel technique simplifies, improves and quickens the single piece non-foldable IOL intrascleral fixation technique. It also has a lower cost and easy learning curve because it is based on existing scleral suture fixation techniques. Our experience spanning the intraoperative and 18 months post-operative course suggests that this technique of SFIOL fixation is safe, relatively easy to perform, useful in hazy corneas and has a short learning curve. Thank you.
Thank you.
Dr. Sayed,
Sunil Kumar, no? He's not. Yeah. Sunil Kumar is there?
Sunil Kumar.
Okay. So you be ready.
Kuchi?
Probably he's there. Syed is there now.
Sir. Sayed.
Dr.
Syed. हाँ. पहले वाला जो था ना. M. Srinivasan is there? Meet Sharma.
Good morning, everyone. At the outset, I would like to thank AIOS for giving me an opportunity to present my paper on the topic subconjunctival triamcinolone in phacoemulsification, a novel dropless approach. What is dropless? Cataract surgeons are always in the search of ways to refine the surgical procedure, improve the result, and at the same time prevent untoward complication and enhance patient satisfaction. One of the contemporary drug administration method is a dropless approach, wherein no topical drops are administered post-operatively. It can be accomplished in a number of ways, where intracameral injection of antibiotic and long-acting corticosteroid, intracameral injection of antibiotic and subconjunctival injection of corticosteroid, and translunar injection of intracameral antibiotic and corticosteroid. These are the references. What is the drawback of conventional regimen? Conventional regimen are given for 4 to 6 weeks post-operative, and it offers very excellent and predictable outcome. But it has certain drawbacks like long and often difficult to follow schedule, non-compliance, particularly in uneducated and rural population, failure to follow asepsis, and incorrect dosage. Also, topical medication itself have inherent issues like corneal toxicity, therapy cost, and all these can lead to undue complications. Why dropless? Benefit to the patient: topical drops free post-operative period, cost benefit to the patient, and no compliance issues. And benefit to the surgeon: no need to worry about the patients wrongly using the eye drops or using eye drops of lower quality, and simplified post-operative follow-up. In this study, we had total of 100 eyes of 100 patients, and which were further grouped as follows. In group A, they were given perioperative antibiotic and steroid with no drugs in the post-operative period, and in control, they were followed up the conventional topical post-operative regimen. In the inclusion criteria, primary senile cataract and patient willing to consent and follow up. These were the exclusion criteria. Now method. Phacoemulsification with IOL implantation was performed by a single surgeon using similar technique in all cases. In the study group, after IOL implantation, intracameral injection of antibiotic, moxifloxacin, and subconjunctival injection of steroid, triamcinolone acetonide is administered. No eye drop is prescribed post-operatively. Now, post-operative assessment of following parameter were done on day 1, 3, and weekly till 6 weeks of visual acuity, intraocular pressure, any sign of infection or inflammation, compliance issue, patient satisfaction, and size of subconjunctival depot was recorded using sirtuximab group A. And the result of the clinical characteristics of the patient were similar. There was no significant difference in both the groups. And IOP was recorded and compared. There was no significant difference in both the groups. Only on the day 1, which was due to the closure of the chamber at the higher pressure. This is the graphical representation of the IOP. In the anterior chamber cells there was no significant difference between both the group. Only we can see that in the study group there were lesser number of the patients which were having cells as compared to the control group which were using topical drops. The visual acuity was in all the patients were less than 6.9 and 6.6, and which was significant. There was no difference in both the group. Size of the subconjunctival steroid was recorded in the study group, and it came to be it decreased in all the group in all the patient, and only in one patient it was there at the day 42. This is the clinical photograph of the patient having subconjunctival depot, and at the day 42 we can see that it has all resolved. All patients in the study group were satisfied with the dropless regimen. 31 patients were willing to opt for the same in the surgery for the other eye. 19 patients who were pseudophakic in the other eye were more satisfied with the dropless regimen. Few females had cosmetic problem related to report, but they were concerned about that. Conclusion. The dropless cataract surgery regimen appears to be safe and effective technique. It is becoming more and more popular as it avoids a lot of issues faced by the patient in the post-operative period, post-operative inflammation, compliance, ocular surface disturbance, and financial burden of therapy. It may be extremely useful, particularly in the Indian setup. However, a large randomized control trial is needed to standardize it. Thank you.
Actually, this can be a double-edged sword. The problem is, so far everything goes well, it is fine. But the moment you end up with a case of end-off, this is an irreversible procedure. So, yeah, but it's not easy to do. In fact, people are now giving transonular also. But if you're going to give subconjunctival, maybe it would be a better idea to wait for a day, make sure there is nothing, and then you give a subconjunctival on maybe the second day or something. But it's a good idea.
Sunil Kumar.
You
is there.
have-
Mr.
we'll go
Sunil
for the
Kumar.
next one. Okay. So Mitali is here? No? Okay. Sunil,
All three, any.
you are Mr. Sunil
Yeah.
Kumar?
Yes.
Yeah, okay.
Actually,
So this will be the fifth paper, intracameral mydriatics was a standard preoperative topical mydriatics in phacoemulsification surgery.
Okay, so good morning everyone. So my topic is the intracameral mydriatics versus a standard preoperative topical mydriatics in phacoemulsification surgery. I have no financial interest in any of the product or technique mentioned in my presentation. So the adequate mydriasis and its maintenance throughout the surgery remains fundamental for the safe and effective completion of the phacoemulsification. And the standard technique to achieve mydriasis involves the preoperative use of the topical mydriatics. However, these topical drops need to be installed multiple times, which increase the patient preparation time, and it may also cause the ocular surface toxicity and sometimes systemic side effects. Also, the maintenance of the adequate mydriasis throughout the surgery can be difficult in some cases, which can jeopardize the successful completion of the surgery. Now, with the ability of this intracameral preparation of the mydriatic and anesthetic mixture formulation like Phenocan Plus in India, it can be the great addition to the armamentarium of the cataract surgeon. And intracameral mydriatic and anesthetic combination has been used in the past in many studies with the good success and safety since a few years. So we planned this study to evaluate the efficacy and safety of the intracameral mydriatic anesthetic combinations and compare this with the standard topical mydriatics in phacoemulsification, which is done under the topical anesthesia. So this was the prospective randomized interventional study. Here the consecutive patient with the senile cataract aged more than 40 years planned for the phaco surgery were included in the study. And the exclusion criteria were history of any prior ocular trauma or the surgery, hypermature cataract, complicated cataract, pseudoexposition syndrome, corneal opacity, etc. So patients included in the study were divided into two groups. The group A, that is the intracameral groups. Here no preoperative topical mydriatics were used, and intraoperatively after the side port incision, the intracameral injection of 0.2 cc of Phenocan Plus were given, and after waiting for 20 to 30 seconds, surgery were continued. And in the group B, that is the topical groups, the topical mydriatics, that is the tropicamide 0.8% and phenylephrine 5% were used 3 times at 10 minutes interval before the surgery. Now at the start of the surgery, the horizontal corneal diameter was measured using the surgical calipers, and all the surgeries were video recorded, and the pupil size were measured before the capsular axis, before IOL implantation, at the end of the surgery. And the pupil size were measured from the screen capture of the recorded video using the ImageJ software, and the pre-measured corneal diameter was used to set the scale. And the primary outcome measures were the mydriasis at different steps of the surgery, and secondary outcome were the patient's comfort during the surgery. So this is a short video clip showing the surgery with the intracameral mydriatics. So this is the surgery done under the topical anesthesia, and after making the side port incision, we injected the 0.2 cc of intracameral Phenocan Plus, and pupil started dilating immediately. And this is just to show the capsular axis. This is done with the 26 gauge 60 tom needles. And this is the phacoemulsification being done with the direct chop technique. By manual irrigation aspirations and inserts. And I have implanted using the hydroimplantation techniques. Coming to the result, the baseline parameters were similar in both the groups. Both the groups had the 40 patients, and the mean age was 64 years in intracameral group, whereas 65 in topical groups. And corneal diameter was 11.6 millimeters in the intracameral and 11.5 millimeters in the topical groups. This is the table showing the pupil size. Before the capsular axis in the intracameral group, it was 7.38 millimeter, whereas in the topical group, it was 8.63 millimeter. And before IOL implantation, it was 7.22 in intracameral and 7.12 in the topical groups. And at the end of surgery, it was 7.13 millimeters and 6.98 millimeters respectively. So we can say that mean change in the pupil size from the capsular exit to end of surgery was minus 1.65 millimeter in the topical groups, whereas it was only minus 0.25 millimeter in the intracameral group. And successful CCC was achieved in all the eyes in both the groups. And patient in the intracameral group reported more comfort and less pain during the surgery. And post-operative course was uneventful. There were no any adverse effects. So coming to the discussion, several studies have already demonstrated the efficacy and safety of these anesthetic combinations and mediatic combinations. And with the ability of this commercial formulation in India, it has given us the alternate option to use in the place of the topical mydriasis. In this study, we achieved a mydriasis of more than 7 millimeters in both the groups. And although the pupils are more in the topical group at the start of the surgery, maintenance of the mydriasis was better in the intracameral group. And our study is similar into the done in the past. Also, the comfort of the patient during surgery was better. This was mainly because of the presence of the lignocaine in the intracameral formulations. Also, the advantage of intracameral use is the decreased patient preparation time. Also, we can change the order of the surgery among the patients. And none of the patients had any adverse effect related to the intracameral injections. So, to conclude, the intracameral mydriatic anesthetic combination are safe and effective alternative to the preoperative topical mydriatics for prompt onset of the pupil dilatation and a stable mydriasis intraoperatively. Also, it decreases the patient preparation time and better patient comfort during the surgery. These are references. Thank you for patience hearing.
Thank you, Sunil. Have you seen any patients where the pupil didn't dilate?
No, sir. Minimum 7 millimeter dilatation was there.
Okay,
We have
because
already excluded the complicated cases like pseudoexplosion.
there are two things which we need to say here. Like there are sometimes it doesn't dilate even if you use the phenocaine plus.
Okay.
Sometimes the dilatation doesn't happen as it happens in topical drops.
Yes, sir.
And the second thing is, as we saw here, the initial dilatation is much better with the topical
Yes,
group
yes,
than the intracameral group. You know, the reason is the effect of dilatation is much better on in the topical group than the intracameral group. Just because the lignocaine is there in the intracameral group, during your surgery, there is no feedback from the iris for the sphincter to contract.
Yes, sir.
That's why maybe at the end of the surgery, you have a little better, larger dilation.
Maintenance of the mydriasis was better.
Yeah, intracameral.
Yes,
but as far as to take home anybody junior who are, doing it, use topical and also maybe you can supplement with intracameral so that you have a better patient comfort and better dilatation.
Yes, sir. We can combine the both.
Did you need to inject the same drug again when you did not achieve the adequate pupil size?
We injected just 0.2 millimeter at the start of the surgery.
Second time or only one time?
Only one time, sir.
And suppose it didn't achieve the desired size of the dilatation, then?
Yeah, we can inject, but in our study we have not injected.
You did not require?
Yes, sir.
Okay.
Thank you. No, Mithali is here. Yeah. Does flax have a place in revolutionizing cataract surgery? The second paper.
Actually, regarding dilatation of the pupil, pre-op evaluation is very important. You must know beforehand which pupil is going to dilate, and on the table it is a choice. If it is not dilating pre-operatively, it is not going to dilate with your phenocaine also. So you will have to think of alternate arrangements.
Do you use NS non-steroidal drops pre-operatively? You don't use? For any patient, you don't use pre-operative non-steroidal? The question is for you, yeah. No, I am asking about non-steroidal anti-inflammatory drops like Nepafenec drops or which keep the pupil dilated during surgery. You don't use that. You have not used it.
Okay. The same or would continue the old gold standard technique?
Now we have started to combine the both.
Combine?
We do the preoperative topical mydriatics.
And then use intracameral.
Okay, so it gives a better dilatation? But preoperatively, the pupil which is resistant and not dilating more than certain millimeter, there here the drop, this drug doesn't help. Okay. Yeah, in that case, iris retractors. Okay.
Yeah.
Hi, good morning. I'll be doing a paper presentation on does flax have a role in revolutionizing cataract surgery? With technological advancement, we know that cataract surgery has now shifted from visual rehabilitation to more of a refractive surgery, and it allows surgeons to customize their techniques, reducing phaco energy and duration, making it more safe and efficient. Since phaco energy is the main culprit for surgically induced trauma to the anterior segment, it leads to endothelial cell loss, affecting immediate post-op outcome. Then femtosecond laser flax came into play. It was originally introduced for corneal surgeries in 2001, and since 2011 it has been used for cataract surgery. It uses neodymium glass with near infrared wavelength of 153 nanometer, which focuses light on pinpoint accuracy up to the scale of nanometers. It produces ultra-short pulses in the range of 10 to the power minus 15 seconds, which limits energy requirements. The earlier studies have not correlated effective phaco time, ultrasound energy, and visual acuity simultaneously. The main aim was to compare ultrasonic energy and effective phaco time in flax and conventional phaco with 2.8 mm incision in grade 3 nuclear sclerosis. We also compared visual acuity in both the groups on day 1 and day 7. We had 100 patients, 100 eyes, 15 each group, and was studied for 18 months duration. Clearance was taken from the ethical committee. The inclusion criteria was age 50 and above, grade 3 nuclear sclerosis, dilated pupil, that is the pupil size more than 6 mm, and it was performed by the same surgeon using the same Stellaris PC machine. Any other patients with any other ocular pathology or complicated cases were excluded from the studies. Patients with spine and neck deformities were also excluded. Written and informed consent was taken. Patients were enrolled on the basis of inclusion and exclusion criteria. Pre-op visual acuity, anterior segment examination, fundus examination, and general examination was done. Patients were allocated into 2 groups using concealed allocation methods, and the procedure of surgery was the same. Intraoperatively, ultrasound energy or effective phaco time was recorded, and post-op visual acuity was recorded on day 1 and 7. These are my results. This is the comparison of ultrasound energy between flax and conventional phaco. The mean ultrasound energy in conventional phaco was 10.96 plus minus 4.06, which was significantly higher as compared to flax, which was 8.58. The effective phaco time between both the groups was also significant. The mean effective phaco time in conventional phaco was 3.21 seconds, while in flax it was 1.71, which was significantly lower as compared to conventional phaco. In comparison of visual acuity, there was the mean on day 1, the flax had better visual acuity as compared to conventional phaco. On day 7, there was no significant difference between both the groups. Several other studies have showed a similar result with possibility of zero EPT with improved surgical technique and modification. Since phacoemulsification works on piezoelectric effects, it delivers energy, facilitates emulsification and aspiration of the cataract. This delivered heat basically damages the anterior segment structure, especially the endothelium. This causes corneal edema on day 1 and reduce visual acuity. Flax has reported to decrease cumulative dissipated energy and EPT, which is due to laser pretreatment. This laser is not absorbed by optically clear tissues, as thus the surgeon can directly remove the lens along the lines of disassembly created by laser. Another hypothesis of improved visual acuity associated with flax when compared to conventional phacoemulsification was due to the theoretical advantage of flax in creating a more precisely centered, circular and reproducible anterior capsulotomy, thus resulting in a more predictable effective lens position with better IOL centration, ultimately causing improved refractive status. Summary: flax is one of the most debatable technological advancements in the field of cataract surgery. It is more time consuming and not cost effective in terms of equipment and low availability, but keeping aside cost factors, flax has a smaller learning curve, intra-op complications and early visual rehab when compared with traditional methods. There's an incremental benefit of enhanced visual acuity on day one, which maybe not be appreciated by the average patient. It comes into play while implanting premium IOLs or where there are complicated cases like subluxated IOL, phacomorphic or mature cataract or patients with low endothelial count, especially Fuchs endothelial dystrophy. Thank you.
Thank you. What was the phaco surgery done? Type of phaco? Is it stop and chop or trench?
Direct chop.
Direct chop. Okay. And did you see any endothelial count difference between these two? No.
No, sir. This is another study going on in a center.
Okay. Thank you.
Were the patients all comparable, like grades of cataract
Grades-
for flax as well as for?
So all patients were comparable in baseline parameters and all had only nucleus 3 grade sclerosis.
Even for flax and for
Yeah,
traditional
we took
both?
the same parameters of NS3 in both the groups.
Thank you. Dr. Srinivasan here.
Dr. Bajaj is presenting. You are there?
Yeah, okay.
Dr. Rajendra, would you like to present after this another keynote?
Good morning, everyone. Today I'll be talking about our work on transdermal drug delivery in phacoemulsification, which is an innovative dropless approach. We have no financial interest to disclose here. As we have all witnessed evolution of cataract surgery over the years with the innovative techniques, devices, and drug formulation. However, we still rely on topical medication to control post-operative inflammation, which is quite an effective route for controlling inflammation. However, there are certain issues which we deals with in the population that we deals with, like improper drug administration, poor compliance, and contamination of the bottles. And all these can lead to various complications. So to simplify the therapeutic effectiveness and compliance, various dropless approaches have been tried, and transdermal approach is one such route where the drug is placed in the vitreous through the zonules, and it remains there for a little longer and releases the drug slowly. So the patient can have a topical medication-free post-operative recovery. It is very effective in controlling post-operative inflammation, and since a single intraoperative injection is used, it is economically viable to the patient also. So we aim to assess the safety and efficacy of perioperative transdermal moxifloxacin and dexamethasone and compare it with the routine topical regime that we follow. And we compared it under the following heads: post-operative inflammation, change in intraocular pressure, and the visual acuity. It was a non-randomized study done on 100 eyes of 100 patients. The population was further divided into two groups. The transdermal group, it comprises of 40 eyes in which 0.15 ml of transdermal moxifloxacin and dexamethasone combination was given, and no post-operative topical medication were used. In the topical group, we had 60 eyes which were followed up with the routine topical medication. So any patient with senile cataract which is suitable for phacoemulsification and were willing to participate were included, and all those patients who had unstable capsular bag or zonular support, who had undergone vitrectomy, pseudoexfoliation, traumatic cataract, uveitis, or if any other intraocular surgery was planned along with cataract surgery, they were excluded from the study. So a standard topical phacoemulsification was done, and a stop and chop technique was used, and this was the injection technique that we used. So after the lens was implanted, the chamber was filled with viscoelastic, and we used a long tip 27 gauge cannula, and we went in through the main port across the chamber, and we tried to reach the sulcus, and once we felt the resistance, we withdraw the cannula a little bit and change the direction of the tip towards the vitreous and injected the drug. And if you are in the right place, you can see a wave of fluid over here. So this is the drug in the anterior vitreous. So the eyes were then assessed for inflammation, intraocular pressure, and visual acuity on day 1, 3, 7, and 28. Statistical significance was set as less than 0.05. These were the patient demographics, and we can see over here that the patients were comparable in all these aspects in both the groups. We compared the pre and post-operative intraocular pressure in both the groups and found that there was no change in the significant change in the intraocular pressure on day 1, 3, 7, and 28 in either of the group. We also compared the post-operative IOP changes between the groups, and throughout the follow-up period, we haven't seen any significant change in the intraocular pressure between the groups. We compared the inflammation in the anterior chamber in terms of the cells and found that there were higher grades of inflammation were seen, significantly higher grade of inflammation was seen in the control group on day 1, 3, 7, and no inflammation was seen on day 28 in either of the group. We compared the flare, and again we saw higher grades of inflammation in the control group on day 1 and 3. However, after that, no significant inflammation was seen in either of the group. As far as the visual acuity was concerned, both the groups have similar visual acuity at the end of the follow-up. We can see over here. And we haven't seen any major complication like zonular injury or capsular break. However, 2 of our patients had minimal bleed during the perioperative period, which stopped spontaneously and it didn't require any measure. So we conclude that the transzonular approach, it has got a greater therapeutic and tolerance response as compared to the conventional topical regime, and also it offers better compliance and cost effectiveness to the patient. There were certain limitations for our study, like a small sample size. It was mainly because of the COVID situation. It was a non-randomized design, and a flare meter would have been more objective in our study. Thank you.
Good, but the dexamethasone has an action of few days maybe?
Yeah.
But how do you expect the inflammation to be very controlled at the end of a month? Or what was the recurrence of, mild redness or mild inflammation in the group where you are given the transzonular injection?
We haven't come across any inflammation after a week or so in the transzonular group, and I think that the most of the inflammation that we come across is during that period only. So,
because from time to time we see patients whom when we reduce the topical steroids at the end of a month or 6 weeks, there is mild recurrence of inflammation. But theoretically it should be more in the transzonular group, because dexamethasone here acts for a few days and then just goes away.
Yeah.
And there is no other drops. Anyway, thank you.
You see, the thing is, as long as if the surgery has gone absolutely fine with no complications, in normal phacoemulsification, you can afford to stop topical also within 3 weeks and nothing happens. So there is no reaction. The same thing is applicable here. If there's been a complication, this will not be enough. You will have to supplement later. The problem again remains that this is an irreversible procedure. God forbid your patient develops end-off or something, you are stuck, you can do nothing about it. So for the little advantage that you are getting, maybe 1 in 1,000 patient, if you lose, I don't think it is worth it, but it is being tried. I mean, it's there. So.
But as you said, sir, the irreversibility is not a big thing like a triamcinolone, because this is just for 24-48 hours. But the biggest problem is we ourselves introducing organisms into the vitreous cavity by injection. That's much riskier.
Everything has gone well, but because you have done something, you may harm the patient. So actually, I was going to ask
One day,
whether
to switch over,
the
there has to be
consent of
some-
ethical committee was taken, and you had told patients also that we will be doing this, and everyone has consented. Yeah, I agree, but okay. Thank
And how
you.
much time does it take to absorb the drugs?
Sorry?
From how much time? No, it must be taking very short time for full absorption. Means clearance of the drug.
The drug lasts for like maximum 5 to 7 days.
No, clearance from the body, from the aqueous vitreous, from the eye means.
The half-life of DEXA and the vitreous is...
There is a risk, no? As you said, there is a risk,
Few
always
days.
a risk.
How was that injection prepared? Can you just tell?
We prepared, we took the preservative-free moxifloxacin.
You can tell the brands, no issues. Yeah.
Vigamox we used.
Okay.
And we used the dexamethasone.
How much of Vigamox was used?
Vigamox we used 0.05 ml of 0.5%.
So you took it in which syringe?
We took in a 30 gauge
Syringe, I am talking of. Huh?
Dispovam.
1 ml syringe.
1 ml, 0.05 ml. Achha, okay.
0.05 ml and 0.1 ml of dexamethasone.
But generally for beginners, this is risky procedure because you are increasing the vitreous pressure.
Yes.
So when you are doing the IA, because they are doing it under viscoelastic, you can have vitreous prolapse through the zonule. So it's only for very senior people. And we will go for the next thing. Yeah, sir.
Yeah.
Okay.
Dr. Rajendra Prasad is a internationally renowned Delhi-based surgeon. He's come up with a lot of innovative techniques for managing hard cataract, and for one of the papers he's presenting now, and he's also done work on posterior polar cataract on what you presented. So, and I think I was fortunate to judge his paper, the best paper, when he presented that also. So, welcome, Dr. Rajendra.
Thank you, sir. Good morning, friends, ladies and gentlemen. And thank you, chairpersons, for giving me this opportunity to be here. And it was my keynote address, but I think because since this has been kept in a pre-paper session, so I'll just read my paper which I read in AACRS. And this paper was adjudged the best cataract paper at American Society of Cataract and Refractive Surgery this year only. So I'll read that paper only, okay? So that would be better. It would be short and...
Yeah.
Even if Avastin or something of 0.1 ml is given, you can see that the pressure increases so much in the eye.
Okay, so the title of my paper is Saving Needle Microcapsulotomy, New Technique to Avoid Argentinian Flag Sign in Intumescent Pearly White Cataract. We do not have any financial interest in the subject matter of this presentation. Friends, we know that the Argentinian flag sign is a self-propagating radial extension of the anterior capsular tear, which typically arises instantly after an initial prick with a sharp hypodermic needle or a sharp tip rhexis forceps when we are raising the flap to create a capsular axis. This was first described by Daniel Perronnet in 2000. Perronnet actually described it to be the sequelae of raised intralenticulaar pressure, the only factor responsible for the propagation of initial prick into a radial capsular tear, along with posterior to anterior compartment pressure, high pressure anterior compartment, propelling posterior compartment, and forward thrust of the nucleus on the back of the anterior capsule, which creates the extension of the capsular tear. Various techniques have been described to neutralize the raised intralenticulaar pressure, to decompress the bag before we start the capsular access, including the saving needle microcapsulotomy, including the small needle aspiration technique, which involves pricking the anterior capsule with a sharp 26 gauge hypodermic needle, followed by simultaneous aspiration of the liquefied lens matter to decompress the bag. Quite often, we have seen that peripheral extension of the anterior capsular tear even happens the moment you prick the anterior capsule with the sharp hypodermic needle. And this is the result, as you can see here in this video. The moment you prick the anterior capsule, before we are able to aspirate any fluid from the capsular bag, the tear starts extending to the periphery. So we had an hypothesis that there had to be some other factors responsible which assist the raised interlenticular pressure to propagate the splitting of anterior capsular tear, resulting into Argentinian plaque sign. So we did a retrospective examination of surgical videos where the Argentinian plaque sign was noted, and we discovered that in reality, it's not the raised interlenticular pressure, the only factor responsible for the extension of the tear. It is the configuration of the initial puncture created to open up the anterior capsule by the sharp tip hypodermic needle or the Raxis forceps. So we create various kind of opening in the anterior capsule, like we use a sharp hypodermic needle or the capsular Raxis forceps. There are different techniques people use, but it's basically the configuration we create on the anterior capsule while opening the anterior capsule. And we know that puncturing the anterior capsule with an ultra sharp beveled hypodermic needle or sharp tip Raxis forceps results into a small linear cut with the open edges along the anterior. So this is the kind of opening we make on the anterior capsule before we start the capsular axis. And we know that there is a raised interlenticular pressure which triggers off a disruptive force behind the capsule within the bag along the discontinuous open edges of the linear cut. So if you make a linear cut, there would be a pressure which is acting on the open edges of this linear cut to open up this. And the linear cut easily opens up, because if you have a linear cut, the cut point of the ends of the cut would start opening up and it would rapidly radialize to the periphery, resulting into Argentinian plaque sign. So this is the basic factor in the formation of the Argentinian plaque sign. And the tear always extends radially along the discontinuous open edges of the linear cut. You must have seen when you are opening the anterior capsule, whether with the needle or with the capsular Raxis forceps, the tear will always extend where the cut is there. It will never extend perpendicular to the tear. It means the cut is the main culprit. It's not only the raised interlenticular pressure, it's the cut we make on the anterior capsule, which is the main responsible factor for the creation of the Argentinian plaque sign. Henceforth, we came up with a hypothesis that if we were able to manually create an opening in the anterior capsule which had a round and regular configuration instead of a linear cut, we may provide resistance against the disruptive forces, thus preventing Argentinian plaque sign. It means instead of making a linear cut, if we can make a hole on the anterior capsule, we can prevent this extension of the capsular tear, whatever kind of the pressure is there inside. And so what we did to open up the anterior capsule, we devised a unique device which is called the saving needle microcapsulotomy. It has a smooth, round, pointed tip similar to saving machine needle system. You must have seen the saving needle. The tip of the saving needle is something like this, and unlike this sharp cut which we have a needle, and if you open up the capsule with a needle, it makes a cut. If you open up the capsule with this needle, you'll have a round hole formation. So if you can make a round hole, the round hole has a resistance because it's circular and round. It will not easily open up. And you can prevent the formation of the Argentinian plaque sign. And this is the device I'm using to open up the anterior capsule in this video. And you can see the animation also. You can use a simple saving needle also, because if you do not have this device, you can just use that 1 rupee needle. Just bend the tip as we do for the hypodermic needle to create the anterior capsular axis, and just puncture the anterior capsule. So when you puncture the anterior capsule with this device, you'll get a hole formation. And this hole actually has a resistance, as I said in the beginning. And at the same time, this will help in the evacuation of the fluid from the capsular bag. So you have seen the evacuation of the fluid from this video and also from the animation video. You can make one hole on the entire capsule, or you can make multiple holes. But these multiple holes have to be within the 5 millimeter zone of the entire capsule. And so that later on when you are making the capsular access, all these holes should come within the capsular access margin. And these multiple holes help to evacuate. Many times these intumescent cataract have multiple fluid pockets. And if you make one hole, you may not evacuate all the fluid pockets. So you can make the multiple fluid pocket holes so that you evacuate the capsular bag completely with these holes. And then once the capsular bag is decompressed, then we can start the capsular access, and you will never have the capsular bag extension. So to conclude, intumescent white cataract is primarily linear cut configuration of the initial prick, which has the potential to spontaneously extend along its open edges, leading to Argentinian flag sign. Saving needle microcapsulotomy with a round regular configuration, like a capsulotomy in true sense, provides resistance against the disruptive forces triggered by the high intralenticular pressure. Initial decompression of the capsular bag facilitates safe and controlled creation of capsular access of a desired size with higher level of efficacy and safety. Thank you very much.
Thank you very much, sir.
So any question I'd like to answer. So since this is not a paper, you can ask me a question. Audience can ask. If any query.
So do you aspirate when you take a puncture? Because
yes.
I saw that your particular design has a hole for aspiration.
Yeah, now actually initially we started with a round tip without hole, just to puncture. And in 90% of the cases it helps. Just puncturing is enough. But yeah, in some cases where you have a flocculent material, which is not liquid actually, because it's semi-solid kind of material, so that needs to be aspirated. So we have now devised a puncture with a hole in it, like we do a needle aspiration. But in needle aspiration, the needle tip, as I said, is a sharp tip. But here the tip is round and pointed. When it enters into the capsule, it makes a hole, and then you can aspirate the fluid.
And what gauge is that needle?
We have started with the 21 gauge. We have brought it to the 20 gauge now, and even 19 gauge is also good. So as large hole, if you wanted smaller hole, then use 21, 22 gauge. But we have all the sizes available with this device.
And now a question, like which company manufacturer is
as I said, sir, you can use just the saving needle only, the 1 rupee. जो needle हम कपड़े सिलने के लिए use करते हैं. Simple needle, just bend the tip, hold it to the forceps and make a hole. Now we have asked Epsilon to make a device to hold the needle, so that you fix that needle in the device. So you can use that as a chopper kind of thing, and then make a hole. But this device as a saving needle microcapsulotomy is available with its Epsilon only. But it's a bit costly. You can use a single 1 rupee needle is very good. Like you just hold with any forceps, the locking forceps, and bend the tip and prick it on the entry capsule.
And when you make multiple punctures, as you said, then where do you start capsular access? When you have done 5 punctures in the center.
Yeah, you start from the center. You start tearing it from the center. The best way is to start.
The same puncture, or you just extend it slightly and then start?
Once you have made the hole, you must have seen in the video, you make the hole, and from that hole make a tear. Because now the capsule is relaxed, it's decompressed. You don't have a problem. Now you can tear it, raise the flap, and then include all these holes within the capsular access. Right. Thank you.
Actually, the same principle applied for what people were doing with phaco. Only thing is they didn't realize that the main reason that didn't extend was because the phaco probe also makes a small round.
Yeah. Dr. Mohan Rajan has come out with the punchor axis. You must have heard his talk. Punchor axis is like you use a phaco probe to punch the anterior capsule, make a round hole on the anterior capsule. But puncture axis, I also tried in some of my cases. Puncture axis, the problem is the vacuum stability is very important, because if you use a little more vacuum, little less vacuum, you won't be able to do it. Little more vacuums, you can just aspirate everything, and you may have a dialysis and all. So that is not very easy actually. See, any technology.
What I'm saying is the principle basically was the same. They didn't realize that it is working because it is making a round hole.
See, any new technology or any new invention has to be simpler than the previous technique. It should be simpler, it should be reusable, it should be effective, and any common surgeon should be able to use it. So that is the idea. So using a sieving needle, see, you may not get the result, but you will not spoil the eye at all. You can restart with your axis if the puncture is not possible or it's not getting the evacuation. You can start with your axis as routine. But this will not make any complications. That is 110% sure. This will not make any complication.
And it is much more controlled.
Yeah.
You have total control on that. But phaco punch is not new. It is something which has
been
presented in US since ages.
Yeah. But that was a phaco punch, and then Dr. Mohan Rajan came out with the punch or axis. So they were same thing. Yeah. But it was not popularized because of its complexity and complications.
Thank you so much.
Thank you. Thank you. We'll go to the next presentation, accuracy of intraocular lens power calculation in traumatic cataracts. Dr. Meet Sharma.
It is. But
Slight difference there. In pediatric cataract, it is not the intralenticular pressure alone. It is also the elasticity of the capsule is different. So it won't tear immediately. In pediatric, if you just puncture it, it won't tear immediately. Yeah. Here it just tears immediately.
Good morning, everyone. Today I will be presenting on accuracy of intraocular lens power calculation in traumatic cataracts. I have no financial disclosure. So, ocular trauma is a major cause of preventable monocular blindness and visual impairment regardless of age, sex and geographical area. And traumatic cataract is very common sequel of ocular trauma. Ultimately, it causes psychological, emotional and professional crippling of the patient. There are three treatment options for the ocular trauma. First, primary corneal tear repair in first sitting and cataract extraction and IOL implantation in second sitting. Corneal tear repair and cataract extraction in first sitting, and we can put IOL in second sitting, and all three procedure we can perform in single sitting. Biometry can be challenging in open globe injury due to corneal surface irregularity or scar. So our aim is to compare the accuracy of IOL power calculation on the basis of postoperative spherical equivalent with respect to the following scenarios. First, primary versus secondary IOL implantation. 2, central versus paracentral corneal tear. 3, using same eye or other eye keratometry reading. 4, visual outcome difference using same eye or other eye axial length. 5, using same eye or other eye IOL power. So this is a retrospective study was conducted in Arvindai Hospital, Tirunelveli by retrieving data, demographic pre and post surgical data from patients who had undergone IOL implantation following traumatic cataract extraction between 2018 to 2020, and total 61 patients were included. Patients who underwent cataract extraction plus IOL implantation following traumatic cataract development were included in this study, and these were the exclusion criteria. Thus, the patients were divided into 5 groups, same as discussed in our aim, and post-operative final corrected distance visual acuity results were obtained and manifest refractive spherical equivalent was analyzed. So, going to results, 82% of male were affected and 56% of right eye is affected. And we have measured and compared post-operative mean refractive spherical equivalent between all subgroups to measure the accuracy of A-scan biometry. So in group A, again divided into two subgroups. In first subgroup, there are 14 patients in which IOL is implanted secondarily, and we got minus 0.43 diopter of mean MRSE. And in 46 patients, we put IOL in primary sitting, and we got minus 0.74 diopter of mean MRSE. And you can see in second group, there is a minimum and maximum range of mean MRSE is minus 5.25 diopter to plus 3.0 diopter, which is very much wide. In group B, central corneal tear group had a minus 0.41 diopter of MRSE, while paracentral corneal tear had minus 0.80 diopter of MRSE. In group C, same eye K reading had minus 0.57 diopter of MRSE, and other eye K reading group had minus 0.61 diopter of MRSE. In group D, same eye axial length group had minus 0.68 diopter of MRSE, while other eye axial length group had minus 0.03 diopter of MRSE. In group E, same eye IOL power had a minus 0.68 mean MRSE, while other eye IOL group power group has minus 0.34 diopter of MRSE. Out of 61 patients, in one patient we used average of K reading, axial length and IOL power between two eyes, and post-operatively we got minus 5.21 diopter of MRSE. Coming to discussion, ages in our study is ranging from 1 to 72 years, and mean age is 29.59 years. And males were more commonly affected, and right eye was more affected, which is 55.7%. Comparing the post-operative spherical equivalent following primary versus secondary IOL implantation, our study shows that the IOL calculation is more accurate with the secondary IOL implantation than the primary IOL implantation. So here the comparison of MRSE between group A, you can see that 85.7% of patients in which IOL was implanted secondarily got MRSE of less than 1 diopter, while only 63% of patients in which IOL was implanted primarily got less than 1 diopter of MRSE. Here you can see an 8.2% of patients in which secondary IOL was implanted primarily got more than 2 diopter of MRSE, while none of the patient got more than 2 diopter of MRSE in which IOL was implanted secondarily. So it suggests that it is better to do A-scan biometry after cornea stabilization and perform secondary IOL implantation, though we have not studied accurate time for A-scan biometry after trauma or primary surgery. So this is the reference. In group B, you can see if 72.7% who had central corneal tear got less than 1 diopter of MRSE. And if we consider same eye key reading, then 75.6% of patients got MRSE less than 1 diopter, while other group had 57.8%. If we consider other eye axial length, then 77.7% of patients got less than 1 diopter of MRSE, while again 68.7% in other group. And if we consider same eye IOL power, then 72.1% of patients got less than 1 diopter of MRSE. So in conclusion, biometry is more accurate in secondary IOL implantation, though it is not statistically significant. Result can be better if we consider same eye K reading, IOL power and other eye axial length, which again depends upon the condition of traumatic eye preoperatively. These are my references. Thank you.
What do you think the reason behind better correlation in secondary implantation?
The stability of cornea, sir. So if we ask the patient to come for a second sitting for cataract extraction or IOL implantation, then we will need some time for cornea to stabilize for keratometer reading. And even if the lens and traumatic cataract density is more, so axial length variation will be more, intra-chamber depth, lens thickness, all the things will be like stabilizing sometimes up.
Okay.
What was the average duration between the primary repair of corneal tear and the implantation when you did secondary?
Sir, here in so many patients, some patients came with little of perforation, so self-sealed perforation. So in those patients directly we did cataract extraction with IOL implantation. Some patient we had primary corneal tear, and in secondary surgery we did cataract extraction with IOL implantation. So there is no specific time, but it is ranging from I think 15 days to 180 days and 180 to 200 days.
So what was the deciding factor in that? patient's choice or surgeon's?
No, surgeon's choice, sir. But sometimes patient can come earlier in our date, so they will be late.
Exactly, that's what I'm asking. That how
Yeah.
how did you decide that we have to operate after 300 days or
So that's
after
why, sir, I
15
mentioned that
days?
exact time
Okay.
of scan biometry.
They haven't done in the study, but for the clinical perspective, you have to see 2 corneal topographic or at least a keratometric evaluation, 2 visits 1 month apart. If it is stable, then that means that the cornea is stable, then you can proceed.
Correct.
It is whole about, sir, scan biometry. So it considers the axial length also, keratometric reading also, and if you consider other eye or same eye power or K reading.
No confusions
what
here.
he's talking about,
One thing
stabilization
is,
of the patient.
Yeah, one thing is stabilization of cornea. If the cornea has stabilized in a corneal injury, that means other things have stabilized by then. Second thing is, once the cornea is stabilized, 99% of the time we can do same IOL biometry. That means that even in a traumatized eye, we will have a predictive IOL position. Post cataract surgery, better IOL positioning by doing a good biometry in a healed cornea or a healed eye. So everything will become perfect. It's not just the cornea, but again AC depth would have formed by then. If you have Sinec A, that is also we know about it. And anyway, axial length is not going to change much.
No, in addition to that, in secondary IOL, you have a major advantage of the spectacle power, So that is also a guideline. Once you know what correction the patient is accepting, that gives you a very good sort of idea about what IOL to implant, depending on where you are implanting it, whether you're going to do a scleral fixation or whether you're putting it in the sulcus. So that is a major advantage at that time.
Okay, thank you.
Sir.
There are 3 speakers left.
Next speaker is Dr. Dante.
Okay, no.
Dr.
Not
Dante.
3 people, only 2.
Dr. Dante is here.
Dante, are you there?
Dr. Karishma Goyal is also there, no?
Sayantan Ghosh is there?
Yeah.
Yeah, please.
And Dr. Karishma Goyal.
Yeah, only 2. This is already done. This one is done.
Yeah, Karishma Goyal. Karishma Goyal is there. Dr. Karishma. Yeah, you're there. You're the next one.
Okay. I think we are on time, so. Yeah.
A very good morning to the seniors and my colleagues. Today my paper is on concept paper on using 3D modeling to learn surgeries. I don't have any financial disclosure. So COVID had disrupted the physical learning process, and the computer simulations has been a part of the learning process. What we tried to have a 3D modeled cornea over which we can simulate the surgical learnings. Basically, the reason being that conventional modeling is costly, copyrighted, and it's scarce. So the objective is to make a feasible model for anatomical learning, reproducible model, tissue properties and disease modeling, if possible, we will incorporate, and surgical step discussion, if possible. What is the crux of this paper is a concept paper. So we sort of concentrated on how to, the journey, what is the journey of this 3D modeling of this cornea. So we started with, we started with a base plate. And continued with the formation of a semisphere over the circular movement along this axis. And actually this is done over a software. And on the spherical cornea, so the sphere is constructed and the elevation points are regular. So first we constructed a spherical cornea. The cornea extrapolated from the spherical cross sections. All the semicircles are same in size. 3D rendered as 1/4 slice rotated around the central z-axis. This is the z-axis. And these are done on the paint software in iPad. And then the oblate, so there are 2 curvatures in cornea. One is primary curvature, this one, and there is another, this one is the secondary curvature. So when we construct one primary curvature over one base plate and one secondary curvature and over another parallel base plate, this is the primary base plate, this is the secondary base plate, we will get 2 curvatures. And if we reduce this curvature, if we remove this curvature, we will get a blending at the curvature points. So these are the 3D models rendered. three concentric circles on two axes, and the primary 2D drawing is that the first curvature on the bluish curvature, the first curvature would be on the 5 millimeter circle, and the second curvature would be on the 7 millimeter circle. There will be blend in the junction. This is the blend. And this there can be two models, cylinder on cylinder or sphere on cylinder. So this is a cylinder on cylinder model. So we first construct the circles, then we extrapolate them as, extrude them as cylinders, and we try to blend the final held up margins, I mean the free margins, we are trying to mold them as a circle or sphere. And this is sphere on cylinder, so the inside is a cylinder, inside is a sphere over which we have constructed a cylinder. Now the cylinder can be extruded as the sphere goes on. We can change the diameter of both the sphere and the cylinder. So the sphere will, the sphere, as many spheres we can include, as many cylinders we can include, they will actually represent different layers of the cornea. Layers after 2D imaging, so these are the layers, they are the three simple square lines. This is as if a sandwich. Now if we can mold this sandwich in a circular fashion, so we can have a base as endothelium and the epithelium. And we can have different tissue properties along the cross sections of these base plates. So what are the materials and methods of this study? This is a very short study. 3D model of the cornea have been created, shared among 9 PGTs and 4 seniors, at least 3 years of experience. So 10 hours to use and learn. Most of the simulations use this R kind of a way to understand what is actually happening with the simulations. Post-learning multiple response method was used to grade. This is a very crude study, and post-learning method was used, proxy method. We have used a proxy method to, basically it's a social research method, but we cannot use any case control or a better cohort study because our sample size is small and our 3D model is just in the journey to perfection. So this semi-quantitative and a multiple regression analysis was made. Parameters were acceptance, simulation, reproduction, and shareability. Now the results, acceptance is quite high among the five gave around 6 of score. We used ANOVA. In the simulation, there's a finding that cumulative frequency shows acceptance takes time. So basically we tend to favor what we have learning throughout the process of our surgical learning, right? In our PG days, in our UG days, we use 2D images, not 3D images. So it takes time. The cumulative frequency shows that it takes time to accept this thing. And it's a reproducible learning because you tend to see the same images or a modified version of the 3D images again and again and again. So it's a reproducible learning. And it definitely is shareable. Across the platforms, it's shareable. So models are accepted over hours. Pilot proves that prospective terms for the same. And software needs upgradation on dynamic modeling. This is static modeling. What we have done is a static modeling. We can do it with a dynamic modeling. Like we wanted them to use different corneal sections over the corneal model. We can have a dynamic modeling where the cornea changes as we made the sections. Layers the microscopic properties can be introduced in the layers like lower endothelial count, like previously traumatic cornea, kind of that. We can adhesion properties can be incorporated. Tissue elasticity coefficient can be incorporated, but it requires calibration. Printing on nozzle technique can be considered, and bioprint can be considered. So 3D modeling on cornea is quite effective. That would be my conclusion. Versions to be bettered on this pilot, but it is quite a new arena and a bright zone to improve for the qualitative learning and assistive learning. These are my bibliography. Thank you so much.
What is the material used for making these 3D corneas?
Sir, these are actually basic models, 3D models. We extrapolated those models as images and modifiable images, PAR. The file can be PAR, can be IPO. And those can be shared over a particular software.
No, so basically the practice is done actually on images, or actually you're producing printouts?
No, sir, printout hasn't yet been done. We have tried.
What is the material used for that
printout?
Yeah.
Sir, PDMS.
What is that?
Polydimethyl xyloxane. It has 3 grades, 1, 2, 3. We can have bioprints too, the cellular bioprints over the PDMS also. And as well as silicon xyloxane itself is available as a 3D print material.
So once the cornea print comes out, how do you practice on that? I mean, do you have an eyeball? Where do you fix it, and how do you practice? How does the student?
Sir, it's actually part of a whole project. So we have to form a frame for any biotissue holding. So we have some marketed frames for biotissue holding, like they hold a part of the cornea, part of the sclera, part of the lens. So we can try drug testing. So we will be using those marketed ones, and if time permits, we can print them too.
And even surgery can be practiced on that if you fix it in the frame.
Exactly.
It gives you the same tissue feel that you get.
Yes, and the tissue feel would be changing depending on the adhesive properties and the printing material we are using. So
very nice, thank you.
Okay, you
Brilliant
can use
concept.
an artificial anterior chamber which you use and put this cornea on top, which should be easy. Already it is available.
Yes.
You don't need to get a frame or anything.
Thank you, sir.
And the last is Karishma Goel.
Karishma.
Yeah, please. Single piece IOL for sutureless scleral fixation.
Actually, these free paper sessions are so interesting, but very unfortunate that only the speakers and the judges seem to be there most of the time. The audiences, and especially in the morning session. But very nice presentation by all of you.
Anyone has questions for any of the presenters?
Do you do it in IIT actually, this printing? Where? IIT Hyderabad. Biotechnology department.
Okay.
So main uses will be for the teaching and training.
Exactly, sir. Because we wanted everything, the software, the printing, it should be free and open source. Because most of the softwares like AutoCAD or any soft edge, solid edge, all this comes with a licensed version. It's quite costly.
And you mentioned about use on mobile.
Yes, sir.
Everybody used it on mobile. So can you just elaborate how they used on mobile?
So there's a particular app. We devised the app.
Okay.
Actually, we borrowed the app. We didn't devise the app. We borrowed the app and sent those models over there so that they can use it at their free time in between the surgeries or before going to the surgeries.
So what exactly they did on that app?
The corneal incision, simple corneal incision.
With finger.
With fingers and or with the stylus.
Stylus.
But actually then the mobile can never give you that feel. You have to have the printout and do it on that. And nowadays even artificial corneas are being manufactured by 3D which are being used in keratoplasty.
Yeah.
The idea is to accept earlier version before going to the robotic surgeries. So we can have gloves which will actually simulate the whatever instrument we are using there, it can cut.
Okay.
It is available in other streams, other subjects, but not in IU.
Very expensive also.
The next people have come. So we'll start actually.
The actual simulations will
She's coming.
It will be version 1 to version X. It will take time.
Yeah.
So it will incorporate all the things we want to incorporate in a cornea. Like we are seeing through any scanning.
10 minutes left.
Whatever
6
we are
minutes.
scanning the cornea, we are having a particular idea about this cornea. So if whatever we are scanning, if we can reproduce over the model and then try the surgery before going to the actual surgery, that will be the actual outcome we obtain.
Okay. Thank you. We'll have discussion after her paper.
Yeah.
So Dr. Karishma, let's start. Yeah.
Good morning all. I am here to talk about the outcomes of intrascleral fixation of single piece IOL rather than multi-piece IOL. To start with, there are various known causes of aphakia for which the various treatment modalities include spectacle correction, contact lens or IOL implant that can be anterior chamber IOL, iris fixated IOL or scleral fixated IOL. So there arises a question, with availability of such a vast variety of options, what is the need of this study? Here I tell you that aphakic spectacles can cause roving ring scotoma and Jack-in-box phenomena, so it is really very cumbersome to wear them continuously. Now coming to the ocular physics, when eyeball move, kinetic energy is acquired by eye muscles which get dissipated into the internal fluid. Here crystalline lens acts as a barrier and provides a stabilizing effect. So in absence of crystalline lens, placing the IOL closer to the center of rotation decrease these centrifugal forces and thereby stabilizing the eye and minimize the complications like iritis, CME or RD. This stabilizing effect gets clearly disturbed in cases of aphakia or when the IOL is placed in anterior chamber. So in absence of a posterior capsular support, sulcus fixation is the best possible option and that can be done through scleral fixation. Now how to fix sclera how to fix IOL to the sclera? That can be done through suture, but again it is associated with the risk of complicated suturing technique and the suture break. Another technique is the use of fibrin glue to fix the haptic to the sclera, but glue is quite expensive and carries the risk of viral transmission. So intrascleral tucking of the haptic came, and all the previous techniques and procedure advocated the use of multi-piece IOL for this study. We evaluated the use of single piece IOL because technically when intrascleral fixation is done and outward force is applied on the haptics to fix them into the scleral pocket. This force can cause haptic break intraoperatively, which indirectly increases the economic burden and disturbs surgeon mental peace. So we evaluated the results of single piece IOL in terms of visual outcome, complications and post-op centration. In this observational study, we have a detailed evaluation including the OCT and the pentacam. Now coming to surgical technique, after infusion of cannula, there was sclerotomies at 2 mm behind the limbus and the scleral tunnel is made parallel to the limbus. IOL was implanted, haptics were exteriorized and tucked into the scleral tunnels. So we evaluated 50 patients. Major diagnosis was of surgical aphakia and follow-up was done for 6 months. We can see here the change in BCVA was found to be significant in our study, while the change in IOP and corneal astigmatism was insignificant, showing that the scleral tunnel did not affect the corneal astigmatism. On day 1, BCVA was insignificant because of the fibrin reaction and raised IOP due to maneuvering, which was managed medically, and after that the BCVA started improving. There were few cases of complications also intraoperatively and postoperatively, which all were managed medically and surgically. So at the end, we have well-centered IOL as seen on slit lamp and pentacam. Sulcus fixation of single piece IOL is not very popular because thick haptics can cause iris irritation, and also the haptics are planar rather than angulated, so they do not vault the optic posteriorly, resulting in complications like iris transillumination defect, secondary glaucoma and pigment dispersion. Our lens has an offset design and also the greater part of haptic is externalized. So neither the haptic nor the optic came in direct contact with the iris, thereby minimizing the complications. Also the haptic of single piece IOL are sturdy in nature, which allow easy externalization, and a thick haptic block the sclerotomies completely, providing better stability and long-term centration. So in conclusion, I can say that after 6-month follow-up, we found our technique of sutureless, glueless, intrascleral fixation of single piece IOL safe and innovative. Here is a small video of our technique. Video. Yeah. So after making the sclerotomy, scleral tunnel was made. Then this is a sclerotomy. Single piece IOL was taken and implanted, and the haptics were grasped and externalized and tucked into the scleral tunnel. I'm really sorry for the poor video quality, but we are in process to upgrade our recording system. Thank you.
Thank you very much. Don't you think the haptic will be very thick?
And
the sclerotomy has to be very
thick. Easy to tuck into the tunnel.
It will be difficult to tuck also in the tunnel.
It's not like proline is rigid, it goes in easily. So this will be difficult to tuck into.
Yeah, sir, that was difficult technically, but the results were
better.
Is it hydrophilic or hydrophobic lens?
Sir, initially we used hydrophilic biotech lens. After that we used hydrophobic. So we have better results with hydrophilic lens because
hydrophilic lens.
Yes, sir, because their haptics are slightly flexible and better stretchability.
Okay.
Hydro. Okay.
How many cases did you do?
50. 50. Okay, thank you.
Mark this.
Yeah. We have to announce the winner also, right?
Or they will announce. You will announce? Take it. Yeah. You take it. Okay, they take it. Okay.
We are supposed to announce that side. We are supposed to announce the result right here.
I don't think so, sir. Because the
with that, we come to the end of this session. I think the next chairpersons are waiting for the next session. Thank you all very much for your patient hearing and for the good presentation, and thanks to all the co-panelists.
And congratulations to all the presenters. You have taken real efforts and it was very good and quite good.
Everybody
good
is a winner
papers.
actually. I think the difference must be 1 odd mark here and there.
Yeah, and keep it up. Yeah, it's a good work.